Good morning.
And good morning to you. How nice to see you. Welcome back. There we go. So, good morning, dear Dr. Rosensweet. Again, nice to see you. Welcome everybody who's here, who's coming up, watching the playbacks. All of that, we're very happy to have you. And happy holidays to everybody. Yeah. Ho, ho, ho. Thank you. um, I have questions, as I always do, and I'm going to get started with number one. You ready for me?
I'm ready.
All right. So, number one comes in as Dr. Rosensweet, why do we need to take progesterone daily when we are postmenopausal, yet we did not make it daily when we did not or were not menopausal most of our lives? This is very confusing to me. Can you expand or expound upon that?
Yes.
Thank you.
Fun question.
Yeah.
Um, what the questioner is referring to is that a young woman puts out progesterone every month if and only if she ovulates.
Mm.
It's the cells that surround the egg that gets released that become the progesterone producing factory. The egg must be released for those cells to get active and produce a lot of progesterone. And that occurs mid-cycle. So progesterone levels are super low during the first 12 days, 13 days of a woman's menstrual cycle. There's some produced in the adrenal glands, but it's really low. And then if a woman ovulates, she puts out a tremendous amount of progesterone, 100 times the amount of estrogen. And so for the last 2 weeks of every single menstrual cycle, if the woman ovulates, only if she ovulates, you know, I'm repeating myself, she gets a huge amount of progesterone. And the right amount. Let me put it that way. So why in menopause wouldn't we just copy nature? And if a woman, when she needs to start taking progesterone, which is usually one of the first things that happens in the 30s, why wouldn't we just treat her during the second half of the cycle with progesterone and not give her progesterone during the first half?
Right.
Well, I had that idea very early on in my career of treating women, and I would suggest to the women, look, nature only gives you progesterone during the second half of your cycle, so when you take progesterone, just take it during the second half. And woman after woman after woman would come back for a follow-up consultation or annual consultation and would say something like, is it possible to take progesterone earlier? I feel so good during the second half of my cycle, but I don't feel nearly as good when I'm not taking the progesterone. Is it possible for me to take it throughout my cycle? And what did I know? I knew what the theory was, but in medicine, you just don't want to go by the theory. And
Right.
and so I said, sure, try it. Try it. Uh, Try it after day 7. And the women invariably, one after another, would say to me, well, I've already tried it. It works great. I love it. And what I learned over time was that women usually preferred to take it right at the beginning of menstruation. So they took it for all 28 days. So I came at it a different way. I wanted to see what progesterone felt like in an actual woman's body to the woman. And invariably, they said every day was the way to do it. And so I followed that. Now, over time, I started to see the wisdom of that because when you produce progesterone, your body levels go up. And that progesterone, part of it gets absorbed in the fat tissue of the body. It's like a strategic reserve. So it's not like you're without progesterone during the first half of the cycle. But what I can say for sure is most of the women I've ever worked with, they like progesterone throughout that cycle. And especially as progesterone production starts getting wobbly. Like progesterone tends to not be produced in a regular fashion earlier in a woman's life than even the estrogen stops being produced. Women's estrogen and progesterone peaks out when they're 20, plus or minus a couple of years, and then they both decline, and then they precipitously decline at menopause. But it turns out that the progesterone declines earlier and deeper, more dramatically than the estrogen does. So a great time to start taking it is when those declines become significant enough that a woman feels the effect of insufficient progesterone. That'll show up in mood, it'll show up in sleep, it'll show up in, she tends to be more anxious, won't sleep as well, or will even get depressed. So even that can happen significantly enough that even in the 30s, a woman can experience low progesterone. Some don't experience it until their 40s, but invariably, the moral of the story is get progesterone right and get it right for your body. And my experience over about 30 years of doing this with women is that most women want to take it all the time.
Wow.
Yeah.
It's a great answer. And maybe next week I'll segue into the other part of that. But well, suffice to say, progesterone is important. Women, most tend to really like it, and it's okay to take it all the way through the month. Yeah.
Mm-hmm.
Cool. Okay, thank you. Number 2, for all of you for all of you out there who take biased and feel great, how much does one take? And then also progesterone. I've been taking bias now for 2 years, and still I've been taking this bias for 2 years, and I cannot get rid of my symptoms. I take 2.5 milligrams biased, 35 milligrams progesterone, and I do not feel well. Thank you.
The most common thing that's going on there is this woman has not figured out her ideal dose for each of the 4 ovarian hormones and the ideal balance between them. And it's amazing. You'd think it'd be simple. Oh, I'm going into perimenopause. I'm going into menopause. Well, here, just take this and you'll be fine. We'll see you next year. It's not that way. A very significant number of women, because of personal individualization, each individual woman is so different from another biologically. For example, some women need this amount of estrogen to regularly menstruate, to be fertile, to conceive, to be pregnant. Whereas other women need this amount, 3 times the amount as this woman. And this woman is normal, regularly menstruating, fertile, carries pregnancy. There's a tremendous individual variation, 3 times as much. And, you've got to find what's the ideal for each individual woman. And not only that, you got to have enough. So for each individual woman, there's something called a therapeutic woman. Therapeutic window. Therapeutic window. That means you got to at least rise up to have enough, but you can't have too much. So you can't have too little, or it's not going to work, but you can't have too much, and that won't work. This is for each individual woman. And then you're dealing with 4 hormones. Some women, by nature, by who they are, tend to be richer in estrogen and less rich in progesterone, relatively speaking, having enough of both. Other women are richer in progesterone and less rich in estrogen, relatively speaking. Then throw testosterone into that mix. You got 3 different variables there. So individualization matters greatly. And having sufficient. Like, I've done the math for this question, and what I learned, I only had partial information to play with, and I want to pull up that math. I only had partial information. She said she was on 2.5 milligrams of
Yeah.
bias.
Yeah.
Is that correct?
Yes.
Well, that would mean she was. I mean, one possibility there. We're not the usual way that that's stated, and that's a very common bias, is 2.5 milligrams per milliliter, not 2.5 milligrams, but 2.5
Literally.
milligrams per milliliter, and then you have to specify how many milliliters you're taking. But I'm going to assume that she's taking 1 milliliter of 2.5 milligrams per milliliter, and that therefore what she's saying is she's taking 2.5 milligrams of bias. And when you do the math on that, let me see, I've done the math here. She is on 0.19, let's call it 0.2 milligrams of estradiol equivalent. Now I'm going to ask people to go to the book to understand what I mean by milligrams of estradiol equivalent.
It's really important, that
The
one.
basic thing about it is bias has two different estrogens and they have a different potency. And estriol is 1/8 as potent as estradiol. So you got to get the math right, and it's based on the ratio. And I'm not going to explain that further, but I do explain it in the book. And so at 0.2 milligrams of estradiol equivalent, it's quite likely that she is not on sufficient amount of bias. And that a sufficient amount of bias, like in my practice, there's a range at which women are satisfied and alleviate symptoms. And it turns out to be 0.8 is the low end, and 2.6 is the high end. 1.7 is the average. So she's at 0.2. She's at 1/4 the lower limit of normal. The high likelihood is she's not on enough bias.
So
So
therefore,
but when this was not explained to her, it tells me that bless the heart of the provider, they don't know what they're doing.
just to say,
They don't understand this well enough. They may be wonderful healthcare professionals that care deeply, but it brings up a bigger issue. The world of training people to expertise in menopause and andropause is greatly lacking. It's really, it's nothing like any other medical specialty at all, where you've got 4-year residencies, 3-year residencies. You want to be a gynecologist, you get to do a surgical residency, then a 3-year gynecology residency minimum. And you're trained, you get training and mentoring by experienced elder statesmen of gynecology, or you want to do that for internal medicine or urology. This is not what's happening in the world of menopause, with one exception. Our training program is very rigorous. And so we constantly see people not understanding the dosage and not getting it right. And if
right?
it's, but I could be way wrong. She gave us information in that question that she's taking 2.5 milligrams. That could be incorrect. She could be taking 2.5 milligrams per milliliter. She could be taking 2 mLs or 3 mLs or 4 mLs. If she's taking 4 mLs, 2 milliliters twice daily, for example, not uncommon, she would be getting enough. But right now, she's not getting enough.
Hence, she's symptomatic.
Yeah, that's my suspicion. But again, without the information, we don't get to know.
Well, maybe she'll
So,
write in and give us some of that information.
yeah.
Yeah. Thank you for explaining that. It can be confusing. Women think they're literally taking milligrams, like I'm taking 3 milligrams or I'm taking 7 milligrams, but they're the milliliters, and then there's the milligram equivalent, which many
Yeah.
women don't know about. And
And
so
a
they,
lot of providers don't understand it either.
right.
So,
And Yeah.
So it's okay. We're at an early phase. The woman is getting some hormones. That's good. And now
Mhm.
it's time for the next level, 2.0 for her. Is to get someone who knows what they're doing. Um,
So I'll get to my next question, but the question came up. I'm also, and I guess this is her, I'm also on 2.5 at a 1-to-1 ratio. Is that still equivalent to zero point 0.2 at 1.1, if I'm saying that correctly?
well, I'm going to ask Facebook user to tell me what's written on the bottle. Does it say 2.5 milligrams per milliliter, 50/50, or 1-to-1? Got to tell us what's written on the bottle, and then how much are you taking every day. Those facts are really crucial.
Got it. In the land of biased, which is
So yeah,
that's
bias has got some math involved.
yeah.
So if the Facebook user wants us to go further, tell us what's written on the bottle. Is it 2.5 milligrams per milliliter, 1-to-1, or it should say 50/50? And then how many milliliters you're taking. And if you only know clicks, tell us how many clicks you're taking and how many milliliters there is per click, because that's variable too. You know, it sounds complicated. And for someone who's trained in this, it's not complicated. You know, before you've making a soup from scratch, it sounds complicated. And after you've made your 10th soup, it's not hard. It's
What's your
pretty
answer?
simple.
Yes.
So I know it sounds complicated, but it's not.
Well, finally, for me, it's not so complicated, but boy, when I got here, it was
Okay,
one
this is
click.
good.
Yeah,
We're
one
getting
click
more
equals.
information. One click equals 0.25 mLs. Now, Facebook user, tell us something else. Does it say 2.5 milligrams per milliliter?
Yeah, because she
I'm
just
going to
says,
assume it does, just for the heck of it. And I'm going to do the math because we have calculators for this.
"What was it that you won? The Peabody math huge."
Here's what's so. This 2.5 milligrams per milliliter, 1-to-1 or 50/50 is what it should say, is and she's taking a half a milliliter a day. She too is not on enough. She's on 0.18 milligrams of estradiol equivalent, or we can round that off to 0.2. And the low end of what alleviates symptoms and produces good test results on 24-hour urine hormone testing is 0.8. That's the low end. The high end is 2.6. The average in my practice is 1.7 milligrams of estradiol equivalent. And this Facebook user is at 0.2. 0.8 is the low end. So
Mm,
0.2 is about a quarter
right.
strength wise of what she actually needs.
And she says that explains why I still have symptoms. And
Yeah.
yeah, that's beautiful to me, that explanation. And I'm hoping that she'll be able to explain this to her provider and get help, and everything will be well.
And I recommend that she download the book from your Facebook page, Happy Healthy Hormones. And I explain this. And I explain when you're starting low in dosage and you still have symptoms, you can gradually increase, not too fast, and keep on increasing the dose, because the theory is here. These are I say theory because these are the kind of things I love to see in person. I like to talk to them. Not I don't You don't need to see them in person. by telemedicine works just fine for menopause. But I like to exchange questions and answers until I understand perfectly what's going on. But at any rate, read the book, because you'll learn how to gradually increase that dosage to alleviate and see if your symptoms go away. They should.
Right. And that book is downloadable, free, the PDF version. I'll put it up again. I put it up all the time. And so you can go ahead and download it. You can also buy it. Uh, uh, it's really quite good, I must say. And thank you for writing it, Dr. Rosensweet. And thank you very much for answering that question, because I do believe there's a lot of confusion around all of that, for sure, for many of us women. Um, you've pretty well brought it down to a science. We're very appreciative of that. Um, I do see this question, and I will get to it. I'm going to move on to number 3 here, which has to do with osteoporosis, which is not fun. Um, Dr. Rosensweet, I have osteoporosis. I'm 61. I'm fit. I'm working. I feel balanced. I'm on 50 milligrams estradiol and 100 milligrams of progesterone at night, and I recently added in testosterone. I am taking zero point 0.5 milligrams of progesterone now. I don't, and that's confusing to me. But anyway, will the above help me to lie down new bone? Would it benefit me, for the sake of osteoporosis, to increase my estrogen and progesterone? Thank you. And then, what is the most important hormone for osteoporosis?
Would you read me the numbers again, Carolyn? There was
Yeah, they're a
something that
little.
wasn't clear there.
Yeah, but I
Start with estrogen. What is she saying?
well, she started actually by saying 50 milligrams estradiol, and then she said, and
Yeah, I
100
think what
milligrams.
she's talking about there is a patch, and it's micrograms. MCG? Is that right?
Yeah, she didn't write MCG, but she said 50 milligrams estradiol.
Yeah, it would be the estradiol. I'm just going to check that. Yeah, this is a patch. Excuse me. That's a pretty good estradiol dose. Some women need more. What I would always love to do is confirm how much she's actually getting by doing 24-hour urine hormone testing. And because when you have osteoporosis, there's a series of things that you want to do that are really pay a lot of attention to. And again, there's a chapter on bone health in our book, Happy Healthy Hormones. And I urge you to read that, because like anything in medicine and life, there's a lot of moving parts and you want to get them all right. Hormones are critical to bone, and having adequate estrogen is critical to bone. When women lose their estrogen at menopause, they lose their bone. They're starting to lose their bone. And it's one of the many reasons it's really important to be taking hormones, estrogen. And estrogen is not the only hormone that's relevant to bone. Bone is produced constantly in our bodies, and it's recycled, as is every organ and cell. That means that the bone you have is constantly being broken down by cells called osteoclasts. They're breaking down that bone.
With a C.
And meanwhile, bone is being rebuilt by cells called osteoblasts. They're laying down new bone. Now, this isn't occurring very rapidly, but it is occurring constantly from when you're a child and till we leave Earth. And what estrogen does is it slows down the breakdown of bone. So when you don't have enough estrogen, you break down bone faster. And we can see that. Like bone, like anything, produces biochemicals when it's broken down. When you break down the protein and calcium and mineral structure of bone, you're putting out chemicals and you're putting them out into the urine. So this is something I highly recommend we do on all our patients. When we see evidence of bone loss, we do a urine check for something called DPD, or deoxypyridinolone, and all this is in the book. And that's the metabolites that's measurable from bone. So one thing I'd recommend to this woman is that she have her healthcare provider see if she's putting out too much bone breakdown products called deoxypyridinolone. If she is, she's got an active bone breakdown process. If she isn't, if that's not elevated, it's something more of the past. And it still can be remedied, but we get more vigorous with active breakdown processes. Deoxypyridinolone, DPD. Every major lab does it. Yeah. And these days, sort of the gold standard is a test called a bone mineral density test. And because this woman says that she has osteoporosis, I'm assuming that was diagnosed by a bone mineral density test. It's an X-ray type test. And I find it very reliable. Nothing's perfect in the world of testing, but I really have a lot of respect. And when I see the word osteoporosis, the next thing we do is see if it's active loss, how active it is. If there's too active a breakdown, we're going to see in the woman's urine or even in her bloodstream too much of the bone biochemicals of breakdown. So we want to see what that's so. Now back to the hormones. The most potent things that affect bones are the hormones. Estrogen slows down the rate of bone breakdown. That means when a woman loses her estrogen at menopause, bone breakdown proceeds much quicker than it ever did. Progesterone supports the cells that lay down new bone. That's huge. I don't know of another substance on the planet that supports the osteoblasts in laying down new bone. So what do we want to do? We want to treat a woman with optimal levels of estrogen and optimal levels of progesterone, and we know what those numbers are. So we treat with the hormones, and then we measure in 24-hour urine hormone testing to make sure that she's in the optimal zone, and we try and maximize it for, we optimize it / maximize it for someone with osteoporosis. Well, testosterone is very important for bones too. And every woman loses her testosterone. So every woman needs testosterone replenishing. There's an
Which
art
you
to
say
that.
is a human hormone, not just a male hormone.
That's correct. A woman has more testosterone than she has the most potent estrogen of estradiol. So testosterone indeed is not a male hormone only. We have more testosterone than women do, but women's testosterone is crucial for many, many, many things. Preservation of the muscles, oh yeah, that's big time, and preservation of the bones. Thyroid is important for bones. So you got to have all these things going, and parathyroid balance is important for bones.
Sorry to interrupt, but a question came up I think is pertinent in regards to this question. It says, how much does calcitonin and parathyroid play into this issue? You just made mention of
We're
that.
talking about something that regulates the levels of calcium and phosphorus in the blood. The parathyroid glands, they do play a role. Now, it's pretty rare in my experience that there's a problem with the parathyroids. And so you're not getting that So when I look at someone who's got osteopenia or osteoporosis, osteopenia is the beginning of major bone loss. Osteoporosis is major bone loss. When I see that, how many times is parathyroid at the bottom of that? Not commonly. It does exist. Sooner or later, one may look into the parathyroids as playing a role, but that's not the really common thing that takes place. I'm telling you the common stuff. Women lose 4 ovarian hormones. Bam, they're gone, or all but gone. And that really matters. And these things relate heavily to bones. Her estrogens, progesterone, and testosterone, or DHEA as well. And hypothyroidism, that means you have enough thyroid to function, but you don't really have the amount that would be optimal for you. Functional hypothyroidism. So your blood tests look normal, they're in the reference range, but really you're not functioning on the level of thyroid you had when you were 25. These play into bones too. These hormones play heavily into bones. We optimize, we test for, measure, and optimize for all of them. They're not the only thing. Bones are constantly, like I said, being broken down and rebuilt. Well, what are they being rebuilt with? Protein and minerals. So the diet must contain adequate protein and minerals. And even more so, you got to be able to digest and assimilate. So you've got to have a healthy gut, and you got to have digestive power. Well, of the many things that are known to decline as people grow older for specific reasons is a decline in the digestive ability. Decline in the stomach hydrochloric acid, for example. That's huge. To properly digest your protein, you need hydrochloric acid. And to properly digest your minerals, you need hydrochloric acid. So there's a lot of moving parts to bone. And that's why I want to take you back to Happy Healthy Hormones, the chapter on bone health. Can bone loss be stopped? Yep. Can people rebuild bone? Yep. Healing is possible. Just get it right. So by the time you're getting osteoporosis, number one, it doesn't guarantee that you're going to get a fracture, by the way. Just because you have osteoporosis does not mean it's going to be problematic. But if you have osteoporosis, you want to be careful. You don't want to do skydiving, for example, or skiing. You want to be careful. You want to take up Tai Chi and approach your walking and standing and turning like a Tai Chi master or a yoga master. You want to be conscious of how you're moving your body, because the important thing about osteoporosis is you don't take the wrong fall. Don't fall. So just because you have osteoporosis does not mean you're going to get a fracture that's going to give you a lot of trouble. And just because you fall and you have osteoporosis does not mean you're going to get a fracture. But if you got osteoporosis, you want to take up getting super present in your body so you don't fall on something hard. That's it. Because you'll still have enough bone to walk and talk.
Pay attention.
So,
Move slowly.
Bones have a lot of moving parts, and it's an important thing. And it's important to go to someone since the hormones are so critical, you want to get those hormones right. One of the most common errors I see, and we've seen it twice today on your first two questions, is insufficient dosages. Not enough. So the 0.05 or 50 microgram patch is not my favorite way, but it's when you're not dealing with the organic oils or you're not dealing with biased, patch is a reasonable alternative. I would want to see, well, how did you do on the 75 milligram patch? You want to maximize the estrogen. You don't want to take so much estrogen that you get into estrogen overdose symptoms. What those are, we delineate in the book once again. What is too much estrogen feel like in a woman. These are powerful hormones. For most women, they're not going to take too much estrogen. They're not going to like it. They're going to get
Mm.
breast tenderness. They're going to get all swelling. They're not going to take too much estrogen. But you'd want to optimize all of these hormones. So you got to go to someone who knows how to read a 24-hour urine hormone test, because that's how you're going to assess whether you got enough, not other testing methods. No, not 24-hour urine hormone testing, not urine 5-point, not a test that says it's 24 hours, but really they're only collecting 5 times during the 24 hours. No, that's not it. It's collect all your urine for 24 hours and send in a sample of that. That's what is going to be really important. You want to get this right. That's what's really important to do.
And then magically, you get to feel better, which is really amazing. Thank you again for that. Um, this is a big question. There are many women who live out of the. What are you laughing at? You're laughing at me.
You must have hit a challenging one.
Well, yeah, and thank you, God, you're here to help me because it is a challenging one, actually, and it's a little bit heartbreaking to me. There are many women who live out of the country, as in the Philippines or Denmark or maybe Tasmania, Japan, even that come up. Many women who live out of the country here in our group having a really tough time getting their hormones right and balanced. We're on our own. We're looking, we're trying, we're struggling. We're not feeling better. Many suffer vaginal atrophy, night sweats, severe loss of hair, don't feel right. Do you possibly have any suggestions for these women and what they might do to help themselves, at least in the interim until, you know, these doctors get trained in all these other countries as it's being worked on?
Yeah, we care about other countries.
I
We've
know.
even gone so far as to acquire patents for organic oils in Canada and in Australia. And here's what I believe, that outside of the United States, it is quite a challenge of finding someone who wants to specialize in treating women in menopause and men in andropause. They exist, I know. I just got back from a conference, you were there, Carolyn, where there's functional medicine doctors from all over the world showing up. There was 5,000 healthcare providers there.
Side note,
And
it was
so they're
incredible.
out there. And anyone who comes to that conference is getting exposed to hormone treatment. And so the job is a job. It's imperative that each individual woman take on a project, a piece of work called go shopping. And what you're shopping for is a licensed healthcare provider who's treating women with hormones in menopause. They're out there. And I believe the products are every country in the world, I believe. And I could be wrong about that. And you can get some decent things out there. Now, but your first job is you have to go shopping. This is not true when you're in a country in the world where you want a doctor. You get a medical doctor, they're pretty uniformly trained. Or you want a gynecologist. In most countries of the world, you can find someone who specializes in treating women. But they're surgery oriented, they're not necessarily hormone oriented. But it's a good place to start. Or you want to find a urologist, someone who specializes in the prostate for men. They're in every country of the world, as far as I know. The training is pretty uniform. Well, it's not true for menopause or andropause. There isn't official trainings. There isn't official board certification. So they're harder to find. And yet, this is the time in the history of the planet Earth that we're born in. So we do what we need to do to deal with that. We deal with what we're facing, what our lives are like. So it comes down to the same thing. You have to be willing to do some research and go shopping. You have to be willing, like a good place to start is if you're in a country and there's someone called a compounding pharmacist. These are the old-fashioned pharmacists that are new-fashioned. They're making up a lot of things from scratch. Yeah, they're still dispensing antibiotics and high blood pressure pills by pharmaceutical manufacturers, but they're also making up things special order to a doctor's prescription or a nurse practitioner's prescription. Compounding pharmacists, go there. They are the ones most likely to know if anyone's writing prescriptions for hormones to them, because they're the ones who are going to be filling these compounded bioidentical hormones. Compounding pharmacists. And go there, show up, don't call them, don't get on a Zoom call with them. Show up at their pharmacy and speak to a pharmacist, not a pharmacy tech, though sometimes these techs are very savvy, by the way.
Quite.
And ask them, is there anyone who's writing you prescriptions for treating women in menopause with hormones? Anyone? And you're liable to get a name. And also ask, who's your favorite? Who do you think is the most knowledgeable? This is one way to go shopping. Plan B. If there's no compounding pharmacist, go to a pharmacy in your country, in your city, and say, is there anyone who is prescribing hormones for menopause? And come up with a list. How about estradiol in a patch? How about a Vivel patch? How about an Estradot, as someone was mentioning? Anyone giving women estradiol in a patch? Anyone prescribing Prometrium? You can do some decent things with these. And you can, if that's the only thing that we had on Earth to treat women with, you can do some good work. I mean, since the 1940s up until about 2002, there were 40 million American women. I'm sorry, 18 million American women. 40% of the women in menopause in America were on Premarin and Prempro. These were pills. These were hormones derived from horse urine, estrogens, and a progestin. And I've never written a prescription for this. This is not my first go-to thing. But if it was the only tool I had, I would definitely prescribe it. And when you interview these women who were on Premarin and Prempro, they did a lot better than their counterparts who had no estrogens at all.
Yeah.
Or no progestin at all. So what I'm saying is go to a pharmacist and ask them who's treating women. Ask your friends. Invariably, some woman has already done the research in your area. If they're menopausal age, if they look good, that's one of the signs. They look a lot better. Their skin looks a lot better. They look a lot more youthful. They have a lot more vitality and energy.
Exactly. They're moving.
You can't tell exactly, but so you have a research project to do, and you do the best you can where you are. And good stuff can happen. You can get the dosage right of the patch. It's not my very favorite. My favorite is using Biest, which is not only estradiol, which is in the patch, but it's also estriol. But hey, you can do some good work with the patch. So that's what you do when you're in another country, is you take on the project. It's called commitment. Commitment is, I'm going to do whatever it takes to get the job done. And as
Right.
far as I know, uh, there's these pharmaceutical manufacturers are giving out prescriptive drugs to pharmacies in every country. And part of the prescriptions they're giving out include hormones. And if you can't do that, if you have the resources, you got to travel to a country where someone's doing it. We have people in Canada traveling to the United States. We have people in Europe who are traveling to the United States, getting their hormones. It's a big stretch. I know many can't afford that. But I assert that if you go to a pharmacist or a compounding pharmacist, you're going to learn who's writing prescriptions for women in menopause. And then you go shopping and check these folks out. You'll get some good stuff. And
Oh
read
my
our
God.
book. That'll help you. That'll help you with dosages, and you can get a lot of good for your whole life by doing what I just said.
That's a really wonderful, optimistic answer. And I thank you very much for that. That question comes to me a lot, and I get a little tongue tied because I don't know. Anyway.
There isn't something I'd like to add to that. I talk to doctors all the time. It's one of the main things I do, and I am happy to talk to any of your doctors. And with Zoom or these other video conferencing, we can talk to anyone anywhere on the planet, pretty much, where there's an internet connection. And we do this all the time. Just a couple of weeks ago, we were talking, we have extensive conversations going on with a compounding pharmacist in Greece. He wants to bring a treatment for women and men to Greece. And
That's
we're doing it with
amazing.
him. We're doing it with him. Elias, if you're watching this, um, and we've spoken to compounding pharmacists in Portugal and in Spain. So I'm happy to speak to someone. You can contact Carolyn. Carolyn will contact me. We'll get a link, a Zoom link to you, and I'll talk to your physician or your compounding pharmacist directly. So yeah, use us too. We want women all over the world to have these hormones, and I can guide them. They can learn what products they have available and can guide them into using them or even getting our stuff.
Incredible, 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 giving, kind you. I want to get to this question too, so we have a little bit of time. When I take progesterone, my hair falls out. Have you ever heard of this?
No.
Okay, moving
Now
on.
there is um, there are a lot of reasons for hair loss, and I wouldn't automatically assume it's because you're taking progesterone at all. I wouldn't assume that. I would go down the list of what of a multitude of things can lead to hair loss. What's going on there? And you lose your estrogen, you're going to lose your hair. You lose your thyroid, you get diminished thyroid, you're going to lose your hair. So I would not begin with it's caused by the progesterone. Occasionally, there are these very hard to explain effects. We even call them paradoxical effects. They're the opposite of what we expect from all kinds of medications and hormones. But it's pretty rare that it's caused by progesterone. There are some women, a small percentage, who have trouble with progesterone, but we always try and figure it out what that is. So I'm not going to automatically say, oh, yeah, it's from your progesterone. No, I would say the best thing you can do is go to someone who really understands hormones and tries and sorts out the many, many different causes of hair loss, many big ones. Hypothyroid, epidemic in midlife in men and women, loss of hair. Imbalance of hormones, too much testosterone compared to estrogen, loss of hair, loss of estrogen, loss of hair. A lot of reasons for hair loss. There's even hair loss specialists. There's actually a nurse practitioner in New York State who her specialty is hair loss, and she has apprised me of the many moving parts with hair loss. So you want to go to a hair loss specialist, or at least someone who's really knowledgeable about hormones, before you conclude that it's the progesterone.
Quickly, I did get to see you speak at this conference in Las Vegas, and we do have that up on the ins and outs of menopause page, and it's right up there on the top, and I would really suggest everybody watch it. It's really good. Um,
How did you get that? We don't have a copy of that yet. We're
I
that
stole it. No, it was sent to us.
Wow. All right. Well, that's interesting. I haven't seen it. I've seen a cell phone. Um, yeah, that was an amazing thing.
It was beyond amazing, and if you were in the audience, it was incredible. You did a great job. So I, with your permission, ask that women do watch that. It's fabulous. Um,
One thing I'd like
sure.
to say is, in honor of Christmas and New Year's, I'm going to take a couple weeks off.
Wait, wait. We just got you back.
Yeah, I'm definitely going to take a couple weeks off,
Okay.
and we'll be back in early January in ins and
Brand
outs of
new year.
menopause. And I'd like to say happy, healthy happy, healthy holidays to
Happy.
everyone.
Is that the
Yeah,
new book
Merry
coming out?
Christmas to everyone. Merry Christmas and Happy Hanukkah and
Kwanzaa.
Happy healthy New Year to you, Carolyn Shapiro, and to everyone on the planet Earth. We wish you
Absolutely.
so well. And I thank you for a great year, Carolyn.
It was a nice wrap to 2022 for me. That is for sure. In regards to the ins and outs of menopause with David Rosensweet, MD. We have 4 minutes left. Uh, I'm going to say the same and just take these 4 minutes to say how much I appreciate you, Dr. Rosensweet. We've been doing this a long time now, and how much I appreciate all of the women and the men who come up and doing this. So we'll all be in the ins and outs of menopause withdrawal for a couple of weeks, but we will be back in January helping men and women with hormones, wonderfully so. And I guess that's kind of that. The cat's behaved and it's nice and quiet here. And geez Louise, I mean, I have so much gratitude. And yeah, that's kind of it. I do have more questions, but we have 3 minutes left. Maybe you can quickly answer this. Why did you choose oils? Put you on the spot there, huh? Sorry.
Not so much. I was drifting into the holiday spirit there. And
Well, oils are holiday oriented.
how about you bring that up when we resume? That'll be question number one.
Okie
It's an
dokie.
important question, and I want to be able to answer it full hearted. And all I have to do is think of the word Christmas and Hanukkah and the holidays, and
Happy you become.
I wish all of us a special sacred time of our year.
Amen to that. Amen to that. Sorry that I interjected that.
No, it's fine, Carolyn.
Okay.
So
Well,
until next year.
Indeed. Until next year. And thank you so much for being here again. Great to see you, everybody. Have a wonderful, wonderful one. You know where to reach me. I'm always reachable, um, as you guys know. So happy, happy, ho, ho, ho. I know they're reindeer like running around like crazy, delivering lots of stuff. So we have to be respectful of them too, right? And Santa, busy guy, as are you. So with that, I will bid you an adieu. A very, very big, huge, redundant, huge thank you for all it is you do for all of us.
Bye bye.
Bye.